Swayam Prabha. Digital India. Educated India.
I'm Dr. Srividya, Professor and Head of the Department of Anatomy, Government, Chengalpattu Medical College. In this series of clinical anatomy discussions, today we are going to discuss about the Erb's Duchenne palsy. At the end of this session, the first year MBBS students will be able to describe what is a Erb's point, list out the nerves forming the Erb's point, the causes of Erb's palsy, the muscles affected in an injury to the Erb's point, describe the position of upper limb in Erb's palsy, and explain the anatomical basis of the abnormality. We'll start with the clinical case study. A 24-year-old female delivered a female baby weighing 3.5 kg vaginally. During delivery, there was some difficulty in delivering the shoulder of the baby. The baby cried immediately after birth. On second day of the birth, the mother noted that the baby's left arm was abnormal and came to the pediatric OP. On examination, the doctor noted that the arm is hanging by the side, medially rotated, elbow was extended. He was not able to flex the baby's forearm easily. The forearm also was extended and pronated. What is the possible diagnosis? And explain the anatomical basis causing the abnormality of the upper limb of the child. So these are the questions that I want you students to ponder over. If you know the answers already, fine, very good, congratulations. If you don't, just go through the next slides. I'm sure you will be able to answer the questions. So just to have a brief introduction of Erb's palsy, it is a nerve injury which affects the upper limb. The main causes are either traumatic or during the process of childbirth. The trauma is invariably a fall from the height. Now, it could be that a person, to break the fall, they may be trying to hold the branch, thereby extending this angle between the shoulder and the neck. So that causes stretching of this upper part of the shoulder region and the axillary region, which can cause the injury, resulting in this palsy. Or when there is a fall from height where the shoulder lands directly first, but there is a continuing momentum which takes the head and the neck forward. So this continuing momentum increases the angulation between the neck and the shoulder. So both the instances causes the stretch, which results in the injury. Similarly, during the process of childbirth in the vaginal delivery, when there is difficulty in delivering the shoulder by the obstetrician, there could be a stretch between the angle of the neck and the shoulder, and that could also result in the nerve injury in this upper part. So all these things can present with the signs and symptoms involving the nerve that supplies the muscles. So that is the basis of the Erb's palsy. So to go back to the gross anatomy, what is Erb's point? It is a part of the brachial plexus. And this Erb's point is where there is a junction of 6 nerves that come together, and that point is the Erb's point. What are the 6 nerves that come together? It is the ventral primary rami of the 5th cervical spinal nerve, the ventral primary rami of the 6th cervical spinal nerve, the upper trunk with its branches, the suprascapular nerve, the nerve to subclavius, and the anterior and the posterior divisions of the upper trunk. We all know that the upper trunk is part of the brachial plexus. So the ventral rami of 5th, 6th, 7th, and 8th cervical spinal nerves form the brachial plexus, and the T1, of course. So it is the upper part of the brachial plexus that is mainly involved, and this is the region that is the Erb's point that is affected because of this trauma. So what are the muscles affected? We just saw the Erb's point involves the C5-6 nerve roots. So the C5-6 nerve roots give rise to axillary nerve, the main nerve that innervates the deltoid, and of course the teres minor. As regards to the musculocutaneous nerve, which has the contribution from C5, C6 and C7, supplies the biceps brachii and the brachialis. The suprascapular nerve innervates the supraspinatus and the infraspinatus muscle, and the nerve to subclavius innervates the subclavius muscle. So, the C5, C6 and the other nerves in the Erb's point are all supplying these muscles, and these muscles are the ones which are affected in the Erb's palsy, and the various actions of these muscles are the ones which are compromised, resulting in the typical position of the upper limb. So, unless you know the muscle's action, you will not be able to know what is compromised. So, the deltoid muscle causes the abduction of the arm. So, the abduction of the arm is taken care by the intermediate fibers of the muscles. This is the abduction. From the midline, away from the body, is the abduction of the arm, and taken care by mainly by the intermediate fibers of the deltoid along with the supraspinatus for the first 15 degrees. The anterior fibers cause flexion and medial rotation of the arm, and the posterior fibers cause extension and lateral rotation of the arm. Because of the opposing actions, any palsy or involving the deltoid only results in the compromise of the abduction of the arm, because the anterior and posterior fiber action cancel out each other. So, deltoid is affected, abduction of the arm is affected. The other muscles that are innervated are the biceps and the brachialis by the musculocutaneous nerve. The biceps brachii has two actions. One is the flexion of the forearm. So, the flexion of the forearm typically happens in the supine position. You will see that the brachialis is the one which is flexor in other positions, all positions rather. So, the flexion of the forearm in supine position at the level of elbow joint is taken care by the biceps brachii muscle. It also happens to be a powerful supinator. The supination action is from the pronated position, the forearm goes for supination. So, this powerful supination action, especially in a flex position, is taken care by the biceps brachii. So, abduction by deltoid, supination by biceps, and flexion by both brachialis and biceps, because brachialis is the workhorse of flexion of the forearm. It flexes the forearm in all positions, whether in extended position, flexed position or mid-flex position. The brachialis takes care of the flexion of the forearm at the elbow joint. So, flexion will be affected if brachialis is paralyzed. Supraspinatus, we already saw, it initiates the abduction of the arm, thereby assisting the deltoid in the abduction of the forearm. In addition, it does act along with the other rotator cuff muscles, namely the infraspinatus, teres minor and subscapularis, to stabilize the shoulder. The infraspinatus, which is innervated by the suprascapular nerve, laterally rotates the arm along with teres minor. Teres minor is supplied by axillary nerve. So, infraspinatus and teres minor together, they rotate the arm laterally. That is why unopposed action of the medial rotation by the subscapularis causes the limb to be medially rotated because of the paralysis of the infraspinatus and the teres minor. The subclavius is a very small muscle. It has a very minimal anchoring and role of the clavicle and not much compromised during the Erb's palsy. The causes, I think we already saw it in detail. The excessive increase in the angulation between the neck and the shoulder due to the stretching injures the superior part of the brachial plexus and the Erb's point, and that is what results in the muscles being affected, thereby resulting in the typical abnormality of the position of the upper limb. So, it could be the fall from height or landing on the shoulder or catching hold of a tree trunk, thereby extending the arm, so increasing the angle between the shoulder and the neck, or during a vaginal delivery where there could be a difficult shoulder delivery resulting in the stretch. The clinical features I think it is very self-evident if you think back as to what are the muscles that are affected, what are the actions of the muscles. So when the muscles are paralyzed, so first the nerve is injured, therefore the muscles are paralyzed. The muscles are paralyzed, therefore the actions are compromised. So abduction of the arm is affected because the deltoid is affected, results in an adducted shoulder. The lateral rotators, namely the infraspinatus and the teres minor, are paralyzed, leading to a medially rotated arm because of the unopposed action of the subscapularis. The flexors of the forearm, namely the brachialis and to a certain extent the biceps brachii, are paralyzed because of the musculocutaneous nerve affliction. Thereby, the forearm is in an extended position. So the elbow is extended. And because the biceps brachii is affected, which is a powerful supinator of the forearm is in a pronated position. So this is the typical position of the upper limb. That is the resultant of the Erb's palsy. Because the musculocutaneous nerve is involved, the name itself signifies that it has a muscular component and a cutaneous component. The muscular component is what supplying the muscles of the arm. The cutaneous component is the musculocutaneous nerve ends as the lateral cutaneous nerve of the forearm, which supplies the lateral aspect of the forearm in the flexor aspect. So that again is compromised. So there is a sensory loss in the lateral aspect of the forearm because of the paralysis of the musculocutaneous nerve, which is in turn supplied by the root value of 5, 6, and 7 cervical spinal nerves. So this is the typical position, and this is the anatomical basis of the typical position. Now, friends, I would like you to all remember just one sentence. Please avoid the term waiter's tip position or policeman tip position or porter tip, whatever be it that is described in the books. I personally feel that it is unbecoming of our profession to denote anything maligning another work, another profession. So we will stick to this position rather than describing it as anything else. So with that, we come to the discussion of the case that we presented in the first part of the session. A 24-year-old female who delivered a female baby weighing 3.5 kg vaginally. Here, we need to look into the sex of the baby, doesn't matter. But the weight does have a significance because of the weight, there was some difficulty for the obstetrician in delivering the shoulder of the baby. I'm not saying all the babies which are large for weight have this problem. Some, depending on the pelvic dimensions of the mother and the position of the baby in utero. So the difficulty in delivering of the shoulder of the baby gives a clue that the upper part of the brachial plexus could be injured. So when the baby presented on the second day of the birth, the typical position of the baby as noted by the doctor, that is, the arm is hanging by the side, medially rotated, elbow extended, is all pointing out, a pronated forearm, all points out to an injury in the superior part of the brachial plexus. So, it will be very easy for you to give the diagnosis and the anatomical basis causing the abnormality if you think of all the symptoms, signs, and correlate with the history. So the possible diagnosis is Erb's palsy. As we know, the Erb's point because of the undue stretching due to the difficult delivery of the shoulder, there is an undue stretching in the upper part of the brachial plexus, resulting in the injury to the Erb's point. So the muscles that are supplied by the nerves originating or taking part in the Erb's point are all affected, leading to the typical position of the arm and the forearm. So the deltoid supplied by the axillary nerve and the supraspinatus supplied by the suprascapular nerve, resulting in the position of the adducted hand because the abduction is affected. The infraspinatus supplied by the suprascapular nerve and the teres minor supplied by the axillary nerve together cause lateral rotation, and when that is affected, the arm is medially rotated. And the musculocutaneous nerve, which is innervated by 5, 6, 7, supplying the biceps and the brachialis, which are the main flexors of the elbow, are affected, thereby causing an extended elbow. The biceps, in addition, is also a powerful supinator, so the forearm is in a pronated position. And the musculocutaneous nerve, by its virtue of supplying sensation to the lateral aspect of the forearm, is compromised. Therefore, there is an area of anesthesia in the lateral aspect of the forearm because of this musculocutaneous nerve. So, this summarizes our clinical case discussion. So, we come to the end of the topic where I would like to summarize whatever that we had discussed in the last slides. So, what is Erb's palsy? It is the nerve injury of the superior part of the brachial plexus. The Erb's point is affected, which is a meeting point of 6 nerves. The fifth cervical spinal nerve, both the 5th and 6th ventral primary rami of cervical spinal nerves, the upper part where the suprascapular nerve originates, the subclavius nerve, which again originates from the upper trunk, the 2 divisions of the upper trunk, namely the anterior division and the posterior division. So, this Erb's point being affected causes injury of all these nerves, and therefore the muscles supplied by the C5-6 are all paralyzed, namely the axillary nerve, the suprascapular nerve, and the musculocutaneous nerve. The injury is typically caused because of the stretching in the angulation between the neck and the shoulder, thereby causing a stretch of these nerves, therefore resulting in the injury of the muscles. The deltoid and the teres minor supplied by the axillary nerve are affected. The biceps and the brachialis supplied by the musculocutaneous nerve is affected. The infraspinatus and the supraspinatus supplied by the suprascapular nerve are also affected. So, the deltoid and the supraspinatus being affected results in an adducted shoulder. The biceps and the brachialis paralyzed leads to a extended elbow and a pronated forearm. The infraspinatus and teres minor being affected causes a medial rotation of the arm because the lateral rotation is affected. So, the typical position of the hand, the adducted, medially rotated arm, extended elbow, and pronated forearm, all that is because of the muscles that are affected, in turn supplied by the C5, C6 nerves. So, that comes to the end of the topic. Thank you very much.